Could you repeat what you said?
Oh, did you want me to share my screen, or do you want to just move ahead with your, I can just tell you when to move ahead.
Those who attend this webinar, um, as everyone knows, today we have the world-renowned scientists and researcher in the field of OCD and Tourette Syndrome. He's with Yale Child Study Center for so many years, and he's done so many pioneering work, and he needs no introduction. So we are all eagerly waiting to hear from you, Jim.
So how large an audience do we have this afternoon?
I think we have 70 people signed up for up to this time. Maybe the numbers fluctuates, but up to this point there are 70.
Good. So thank you for the invitation again. And again, I'm sorry that I'm not there in person in Tehran, such a wonderful country, such good people to make this presentation. And Javad has asked me to talk about some of the recent findings with regard to what we know about the neural circuitry of Tourette syndrome and how that might actually lead to some form of personalized treatment. And I will be covering a lot of ground, and interestingly, there is some brand new research that I'll also be mentioning that is really fascinating to me, but in some ways it sort of leaves open many questions that still need to be resolved. And it would be wonderful to be able to work with the team there in Tehran to move ahead this field of study. So typically in our presentations, we need to make some account of our disclosures. And I'm very fortunate to have a lot of research funding as well as royalties. Interestingly, we're currently working on the next edition of our Tourette syndrome book. And this is the one that was published a few years ago, but we now have, I think, almost completed the second edition. And interestingly, some of the people whose work I'll be presenting are individuals. I think there are probably 11 different countries that are represented in terms of the contributors to this textbook on Tourette that was published by the Oxford University Press. So I think with that, I'll move on to the presentation and just say the reason that I actually got into this particular field of study was because of Michelle Hampson, and she's the very first person whose picture you can see there. But remarkably, I guess another person that I need to call out is Brad Peterson, who is here, and Denis Sudoharsky, and Michael Block, and also Flora Vaccarino. But they've all really contributed to, and it's interesting with Flora, we're currently working on a paper that we're about to submit to the Journal of Science with regard to a refractory case of Tourette syndrome that we may briefly discuss after the presentation. And as we discuss this refractory case of obsessive compulsive disorder that will be presented. So my perspective, and I think I probably shared this slide with you in the initial presentation, is that we're all interconnected in this ever-changing world of ours. And although there's a lot of things to be discouraged about, certainly the pandemic among them, but I guess I'm not sure if the right word is frightened, but we need to do everything we can in my country to make sure that our current president is not re-elected. So if any of you have any way of influencing that, please let me know, because it is really a shame. He is a person who really is intent on dividing people, and the reality is that we need to interconnect. And what's fascinating to me is that, and this is actually some work with regard to social networks that's been done here at Yale, is that all of us are interconnected in one way or another, although we have certain nodes that are special connections for us. And Also, interestingly, the simulations that have been done by the physicists with regard to dark matter and dark energy also suggest that this is constantly changing, and all things are interconnected. But what we'll be talking about today are neural circuits and our connectome. And the basic bottom line is no one neuron does anything. It's only when neurons work together that we're actually able to accomplish anything with our human brain. And the connectome is this comprehensive map of all of the neural connections in our brain, and it's often referred to as a wiring diagram. Typically, what people will do is look at this during a resting state where an individual is not asked to be doing anything in particular, and they're just looking at the interconnections within the brain. Although it's fascinating, there are also ways of looking at this issue with regard to activity during particular events that one is focused on with regard to particularly certain symptoms in the clinical realm. So one of the findings from Yale, although interestingly, the data that they are referring to, and I'll go through this in a bit more detail later on, is that our connectome, the way in which our brain is interconnected, the neurons and the circuitry, is fairly stable. And interestingly, this data that was published just last year looked at data from over 300 individuals followed for more than 2 years. And interestingly, it was quite remarkably stable over that period of time. And as they suggest in their paper, this may set the stage for a personalized medicine. But what's also equally interesting, and I won't be coming back to this until probably towards the end of the presentation, but some of my colleagues that I've been working very closely with at the University, or Washington University in St. Louis, have also been tracking individuals with Tourette Syndrome. And they currently have, I think, 202 individuals that they've published data on with regard to what the interconnections are. And there's some really fascinating findings. As I'll be talking about, it seems as if the children with Tourette have a pattern of interconnection that is much more similar to what you see in the normal adults. And it's sort of vice versa. The adults with Tourette syndrome seem to be more like the children of the normal controls, although all across the board, the patterns of conductivity that they found with regard to Tourette syndrome, whether you were talking about a child, an adolescent, or an adult, were distinctive from the patterns that were seen in the normal controls. And there may not be time to talk about it, but it's always fascinating to me to think about the fact that in Tourette syndrome, the interconnections are a bit different. And I think that that may account in part for perhaps some of the unique features of Tourette that include things like the high level of creativity that we see in some individuals with Tourette syndrome, because they may see the world in a somewhat different way than the rest of us do. But let me come back to the data that I was mentioning, where they actually did a very comprehensive analysis of the connectome data from 303 individuals across 4 sites. I think it included Pittsburgh. I think there was a group down in Texas as well. And I think I can probably take a look at what the messages are, but it's really quite remarkable that they took all of that data and they found that it was quite stable over time. So there are many unanswered questions. You know, when does this connectome begin? And how can we understand it? What is the typical developmental trajectory for an individual's connectome? And as I mentioned, the emerging data from Tourette really calls this into question. And in terms of the stability of an individual's connectome over the course of decades. And then, of course, with regard to the issue of personalized medicine, one of the issues has to do with can we come up with, using a personalized medicine approach based on our understanding of an individual's connectome, find a way of predicting who actually is going to respond the best to certain medications or behavioral interventions. So this brings us to looking at the data that we have done with regard to the work that I'll be presenting later on. And basically, what do we know about the circuitry that underlies Tourette syndrome? And basically, there's a lot of information that focuses on the basal ganglia and how it interconnects with the cortex and with other areas of the brain, and that there leads to some disinhibition of specific cortical striatal thalamocortical circuits that precede the occurrence of tics and the urges that precede the tics. So I think probably all of you are familiar with the concept of the premonitory urge, but this is something that we have studied in some detail here at Yale. And typically, although it's usually something that a child has difficulty describing until they're probably 8, 9, 10 years of age, but basically a premonitory urge is a feeling someplace, sometimes a specific feeling in a particular part of the body that they need to do a tic, that there is an urge to do it. And what's fascinating about these urges is that if you actually give in to the urge, then it's a reinforcing condition and you want to do another one. And this leads to there being what we call a bout of tics, a series of tics one after the other. But typically the bouts of tics are spaced in between one another. So there are bouts of tics and then usually a space of time and then another bout of tics. And what's fascinating is that we've actually done analyses where we've looked over time and have found that the bouts of tics also occur in bouts, and even the waxing and waning that is so typical of Tourette is something that waxes and wanes in terms of the symptoms themselves. So a good deal of information that we have focused on here at Yale concerns the supplementary motor area. And that's up here on top, that's sort of in a darker gray. And this is basically the neural circuitry that we were talking about, going from the cerebral cortex to the basal ganglia to the thalamus and back again. And what's fascinating is that when neurosurgeons have actually stimulated that area of the supplementary motor area, individuals who have had surgery that are leading the neurosurgeons to focus on that area, often will report when they just have a stimulation of that region that they have an urge to move. So these aren't individuals with Tourette syndrome, these are individuals who, for one reason or another, are undergoing neurosurgery. So there's a hint that there may be something going on in terms of those premonitory urges that is based in this area called the supplementary motor cortex. So it's interesting too, because if you actually stimulate the supplementary motor area, you can also produce movements and urges that are strikingly similar to tics and the premonitory urges. So this is something that really has reinforced in our mind that this is a key area that we need to focus on. And it's also interestingly the case that when you actually stimulate the supplementary motor area, the movements that are induced can have a variety of complexity, from simple motor acts to more complex movements. And this is very similar to what we have learned from our Tourette syndrome patients. So this is a paper that I did with Michelle Hampson some years ago, and maybe I can just go to the data. But basically, we were looking to see what are the brain areas that are co-activated with the motor cortex when an individual is having a motor tic and also when they're having an intentional movement. And we were actually able to look at this in a good number of Tourette patients as well as normal controls. And it was published in Biological Psychiatry some years ago. And basically, what we found was that it was a very similar kind of patterning that we saw in terms of the correlation between the time course that was seen with regard to the motor movements and the tics, except for the Tourette syndrome patients, somehow, for whatever reason, had this broader profile in terms of what was seen, and that was significantly different from the normal controls. And the precise location of them in the motor cortex was specific to each of the patient's tics, and that was identified for this particular study. This has also been an area of active interest for colleagues around the world, and I guess there was a team some years ago, although this is just 2017, where they actually performed a modeling analysis of fMRI data collected during a motor task of individuals with Tourette syndrome. And basically they were asking what areas of the brain are activated during a tic behavior and what are related to the intrinsic or the task-dependent conductivity. And they found that the intrinsic conductivity was abnormally increased in the premotor network for the individuals with Tourette subjects. And more specifically, they found this connection strength between the basal ganglia and the primary motor cortex. And there was an association there with regard to disease severity. And this pattern was mirrored by a negative correlation between the connection strength in the supplementary motor area and the motor cortex. And this is basically the pattern that they saw. So, and interestingly, Mario Porto has been a good friend of mine over the years. He's a neurosurgeon, and we have worked together over the years. But what was fascinating is the connection between the motor cortex and the basal ganglia was associated with the stronger that connection, the higher the tic severity score was. So the stronger your connection is between the basal ganglia and the motor cortex, the more severe your tics were, although this was just 24 patients, so I think it may be a little more difficult to surely generalize in terms of the findings. In contrast, if you look at the connection between the supplementary motor area and the motor cortex, what you see is an inverse correlation, suggesting that there's actually, if you're actually able to increase the activity in the supplementary motor activity, the motor area, you actually may be able to decrease the severity of the tics. So these two reverse correlations showed effects that were specific in relationship to the disease severity. And the greater the imbalance between the subcortical and the premortal connectivity towards this motor cortex, the higher the severity was in terms of the tic severity score that we measured with the Yale Global Tic Severity Score. And it's just fascinating that there is what we might call a tug of war between these two interconnected circuits that focus on specific areas of the motor cortex that are activated during a particular tic behavior. So if people have questions, please, I'm probably going through this a little too fast. But what this led Michelle Hampson and myself and others, and Dennis Sudoharsky, Michael Block and others, was, gee, if there was some way for us to actually help the individual themselves control the activity in their supplementary motor area, would it be possible that they could actually reduce the severity of their tics? Is there any way that we could put the patient themselves in charge of the intervention that we were going to be offering? So this is just fascinating about this phenomenon and technique called neurofeedback. And neurofeedback involves learning to modulate brain function through real-time monitoring So this means the individual actually has to be in the magnetic resonance imaging device. And what's fascinating is that you can actually come up with ways of looking at this. And what we were able to find is that, yes, it was possible to encourage and to have individuals with Tourette syndrome actually activate or deactivate their supplementary motor area. What was also fascinating was that it was also critically important for us to be able to detect with a high degree of sensitivity and specificity the small number of voxels of increased activity that we saw that were associated with when they were actually having their tic or mimicking their tic. And of course, when you talk about motor tic behaviors and the fMRI machine, there's also a risk that you may actually be causing some difficulty in terms of really site specification if there's any kind of head movement at all. So I'm not going to go through each one of these papers, but basically real-time fMRI neurofeedback has really caught on in the scientific world. And this is just a few of the papers that have been looking at this with regard to a variety of different conditions. And interestingly, in preparation for my presentation with you today, I looked through the current literature, and literally there are 30 different scientific articles about real-time fMRI neurofeedback that were published so far just this year in 2020. So real-time fMRI have been, people have been trying to use it to improve cognitive and perceptual processing as well as symptom improvement. So it's really taken off as a field of investigation. Okay, so what is neurofeedback? And as I mentioned, it involves learning how to modulate brain activity through real-time monitoring of an individual in their very present, right now, brain state. And it is a potentially powerful method to perturb and probe brain function. And as I mentioned, it's emerging as a potential clinical intervention. So our question was, could it be used to help individuals learn to control their tics and urges? And this was the study that we had funded by our federal government here in the United States. It was a double crossover design with a double-blind sham-controlled study. And so individuals were randomized either to get a sham intervention or the active intervention. And the way we designed the study, it was such that we didn't think that there would be an enduring effect of the real-time functional fMRI neurofeedback intervention. So after just a month or so, we actually had the individuals that were assigned randomly to the sham condition to actually get the active intervention and vice versa. And this actually turned out to be somewhat problematic, and the current trial that we're initiating doesn't have that crossover design in quite the same way, because as I'll mention in a moment, what we found was an enduring positive effect with regard to the real-time fMRI neurofeedback for the individuals with Tourette syndrome. So we talked about this tug of war, and basically what we're trying to do in this case is actually strengthen that connection between the supplementary motor area and the motor cortex where the individual is actually having their tic. So can our patients learn to regulate the activity in the supplementary motor area? And this was published this past year or this current year in Biological Psychiatry. So basically, we gave them a number of different instructions. I'll go through this in a bit more detail in a moment. But basically, they are actually able to monitor, they're actually looking themselves at the activity of their brain region that is involved in controlling their tics in the supplementary motor area. So it's real-time neurofeedback that we're talking about. Of course, there's a little bit of a delay in terms of the being able to monitor the activity because of the nature of the magnetic resonance machine. It doesn't give you an instantaneous, but it's just a matter of milliseconds off from what you actually are, the level of activity seen in that particular brain region. So basically, we were asking them to come up with some strategies that would actually control it, but they were actually able to see the differences in their level of brain activity and actually have that be a marker for whether or not they were successful in being able to regulate the activity in that particular very small portion of the supplementary motor area. So in the initial 3 to 6 functional neuroimaging runs, they were instructed to imitate their most troublesome and common tics. And because of the concern about head movements, we asked them not to imitate their head movement tics, but to imitate specific tics, and then to rest in alternate blocks, and they were cued by this term rest. And then we analyzed the data in a voxel-wise t-test comparing the rest blocks to allow the identification of the region where the controlling the tic-relevant musculature was particularly important. And it turned out that these were relatively small numbers of voxels that we were focused on for each individual patient. This is basically what the individual that would be seeing in the magnet. When you actually, the individual patients were cued to either increase the activity in their supplementary motor area or decrease the activity in the supplementary motor area. And they were actually able to then train themselves using this kind of information in real time to either increase or decrease the activation in the supplementary motor area in that very small area with, I think it was something typically 15 to 20 voxels. So it was not a very large area of the brain that we were looking at. So this is basically, this is somebody in the magnet. Basically, the image that you see on top is the kind of thing that they would be seeing themselves in terms of monitoring the activity that they were having. And there was a very specific region of the brain that we were focused on. And so what we found was that, yes, indeed, in this sham-controlled trial of real-time fMRI, that was successful in actually reducing in adolescents with Tourette syndrome the severity of their tics. And what was fascinating is that when we took a look at the time course, it wasn't just a few hours or a day. It was literally, there was an improvement over the course of weeks. This data from Rance et al. From 2 years ago also summarizes the data with regard to a trial that was done with regard to obsessive compulsive disorder. And in that study, they were actually adults with OCD, and it was a different brain region in the area of the brain that is associated with obsessive compulsive disorder. And again, it was a very similar design in terms of they're being asked to come up with strategies to actually increase or decrease their obsessive compulsive symptomatology. So there are lots of questions. Can these findings be replicated? Why does neurofeedback have an enduring positive response? Can big data be used to identify who these responders are? Are there any resting state biomarkers that are predictive of the response? Would it make sense to schedule future neurofeedback sessions for those Tourette syndrome patients? And can we actually see evidence that the connection between the supplementary motor area and the motor cortex is actually individually increased in the short term? Because if we can increase that activity, then there's a likelihood that we'll see a reduction in the tic severity. So there are all sorts of questions that remain. And this brings us to a number of other unanswered questions. what is the right design to optimize this intervention. And as I mentioned, if there really is an enduring positive response, then in designing future clinical trials, we need to take that into account. And would it make sense if it really is effective for weeks, over the course of weeks to a month or two, would it be sensible to actually schedule future neurofeedback sessions for those patients that did have a positive response? And how can we make sense of the equivocal findings? This brings us back to another issue that we'll be talking about when we talk about the clinical case after this presentation. And what I mean by that is that typically for refractory cases of Tourette syndrome, we sort of go through a series of steps, beginning with cognitive behavioral intervention and pharmacotherapy. And then if the patient is not responsive to a variety of different combinations of treatment with regard to the pharmacotherapy, we may try other interventions if the tics are still quite severe. And they include electroconvulsive therapy. They also include something called transcranial magnetic stimulation, or this RTMS that's mentioned here on the third point. And what this refers to is that we actually did conduct a study of transcranial magnetic stimulation for our Tourette patients. And while we initially in the pilot study found some positive results, it was not, it was more equivocal in terms of the longer term study. And it's interesting too, because when you use RTMS or transcranial magnetic stimulation, being able to really maintain the stimulator over a specific area in the cortex can be a challenge. And that may have contributed to the variety and not entirely positive findings across the number of patients that we actually studied with regard to RTMS for Tourette syndrome. And then of course, if that doesn't work, we go through other kinds of procedures like deep brain stimulation. And we've had probably 10 or 12 patients over the years where even that has not been helpful in terms of reducing the tic severity. And in that case, we've actually turned, at least in one or two cases, to neurosurgical interventions. Is there a question?
I guess we lost the slides.
Oh. When did you lose them?
I guess just 3 minutes ago, or maybe the last 2 or 3 slides. I have it from the email you sent me, but it's
well,
not.
Maybe why don't you go ahead and use your slides in that case?
Okay. Okay.
So move back a couple of them, not this one, but the one before that.
Okay. Is that it?
The one before that. The one before that. Just keep going back. One before that. Okay, so this is this is the findings that we had from that study that I was mentioning, where we actually followed the time course, and there were 20 subjects with Tourette syndrome, and there were 17 subjects with adult subjects with OCD. And basically, the pattern that you see in the next slide. Can you move to the next slide? Was what I was mentioning before, where rather than just for a few hours or a day or two, and if you look at the real-time neurofeedback, and this is actually combining the data from individuals who either in the case of the Tourette syndrome, we were stimulating the SMA, and there was another region of the cortex that was being stimulated in the adults with OCD. What we saw was that on average, and of course there were some patients that showed a marked reduction, and there were others that showed no reduction at all, but there was a significant overall improvement in the tic symptoms over a 2-month period as we were able to monitor these patients. The next slide. So is this really true? Can we replicate these findings? Why does neurofeedback have an enduring positive impact? Can big data be used to identify responders? And here we come back to the connectome question that we'll be talking about in a moment or two. And are there any resting state biomarkers that are predictive of response? Is there any way, if we looked at the patterns that we're seeing in terms of the connectome, that was actually predictive of who would actually have the best response to the real-time fMRI neurofeedback? And we didn't have an opportunity to look directly at whether or not the SMA motor cortex connivity was increased in the short term. And given the fact that there's so much data with regard to other basal ganglia structures, we need to also look at questions about the conductivity between the putamen and the motor cortex as well. Next slide. So as I mentioned, I'm not sure this was the right design to optimize this intervention because we did see this enduring positive effect. And would it make sense to schedule future neurofeedback sessions? Could this actually be a form of treatment? And so that's something that we're actively exploring with Michelle Hampson and our colleague Dennis Sudoharsky, among others. And I guess this brings us back to this question about, given the equivocal findings that we had with our transcranial magnetic stimulation study, where we actually used the supplementary motor area as the target. As I mentioned before, we saw a positive response in the pilot data. And then when we did the larger data that we did actually with colleagues from Columbia University, what we found was a variable response, and it was close to being significant, but the overall significance wasn't sufficient to warrant saying that this was an intervention that would really make a difference. And so this brings us to the part that I'll be talking about next, which is what about the recent connectome findings for children versus adults with Tourette syndrome? And I briefly mentioned this before, but it's really a fascinating set of findings from our colleagues at the Washington University in St. Louis, and I'll be going through those in a little bit of detail. And it would be fascinating if we could work with our colleagues there in Iran to replicate and extend some of these findings with regard to the real-time fMRI, if it really is potentially an effective intervention. So the next slide. So as I mentioned, what about the recently published connectome findings by the team at Washington University in St. Louis? Next slide. Next slide. Or just keep going, yeah. So basically, they actually took a look at, and some of the people that are on this paper, I guess Bradley Schlagar, Kevin Black, and Deanna Green are people who are good friends of mine, as well as close colleagues. I'm actually a mentor for Diana, who's recently been promoted there on the faculty of Washington, University of Washington in St. Louis. And they're also contributors to the book on Tourette syndrome that I had mentioned to you, is coming up with a new edition. And when that new edition comes out, I'll be sure and send Javad a copy, which I think would be potentially of interest. So basically, they were able to distinguish the patterns of the resting state conductivity between individuals with Tourette and a matched group with normal controls. That's good. But the really fascinating finding was that the brain networks for children were more like what was seen in the normal controls who were adults, and the opposite was true. So that the brain networks for the adults with Tourette syndrome appeared to be more similar to what was actually seen for the children in that control study that they did. Next slide. So this is a little confusing, but basically what we're looking at is for the control group, they're the ones with the true age. So if we look across the red line with the red dots, what we see is true in both the child TS features and adult TS features, because that's the normal control data. But what is fascinating is that if you look at the Tourette syndrome patients, and that's the blue dots and the blue lines, children with Tourette look more like the adults in the normal control population. Adults with Tourette look more like a persistence of the childhood level of activity with regard to their connectome. But how can that possibly be true, and what sense does it make? On the other hand, they actually had, next slide. Next slide. Go ahead, back up just, yeah, that's the one. So basically, I like the two circles there at the bottom left. The sort of overlap between the children and the adults was teeny, 25 over 1,000 in terms of the weighted features with this connectome. I guess the other thing that when I looked again at the paper that I guess was surprising to me and a little disconcerting was that there was a reference to the supplementary motor area, and I did send Javad this paper, but it didn't turn out that at least in terms of the resting state, that the supplementary motor area was featured very much either in the child or the adult areas of increased activity in terms of how they analyze this big data. And as I mentioned, with regard to how you would actually see the difference between the individuals who were normal controls and their connectome and the individuals with Tourette syndrome, it was a very different kind of classifier that you actually saw in terms of the children having a very distinctive pattern with regard to that pattern of activity in terms of their connectome versus the adults. But I think the key finding, if you go back a slide, is the fact that there is this really remarkable difference between adults and children with Tourette in terms of the patterns that you see and what they were able to come up with when they did this very extensive big data analysis of the connectomes. And it makes you wonder if you were actually able to see in a child something that looked more like the children of individuals with that were normal controls, would they actually be at risk for a more severe form of the illness? Next slide. Next slide. Just click again. So given the heterogeneity in the developmental course of Tourette symptoms, there's a great need to be able to predict future clinical outcomes for children. And this multivariate machine learning classification that they were using in St. Louis, when you apply that to functional brain networks, may allow us to make such predictions. Which children are likely to improve over the course of development and which are not. And these findings suggest that the functional conductivity, these maps may actually be able to be used in the future to identify which children are at greatest risk and perhaps the ones that are not. It reminds me of maybe a decade or two ago when we were hoping that we would find single genes, and we actually have found single genes that are associated with Tourette syndrome, but for the most part, the genetic heterogeneity is really pretty impressive, as is the clinical heterogeneity as well. Next slide. So I'm coming to the end of this presentation. So I guess I would just say that I still have a lot to learn. and we all do. But it's really fascinating to sort of look at this interconnection between different brain regions and how we've structured that over time. But thank you for listening, and I'd be glad to answer any questions if I can.
Oh, thank you, Jim. Thank you very much. It was fascinating, a wonderful presentation. I'm still confused about the last few slides. The thing with the differences between children with Tourette's versus adults with Tourette's, and that's very fascinating. Um, um,
And so I guess one thing to say about that, Javad, although you haven't asked your question yet, is that they use this way of looking at big data. So you're literally looking at voxel by voxel across the entire brain network for all of these individuals. And you're asking the questions, how can I make a distinction between those with Tourette and those without Tourette? And then they also, for whatever reason, made the decision to divide the sample into 3 groups. And there were a group of children, a group of adolescents, and a group of adults. And when they just looked at those separately, although now we're talking about Ns that are relatively small, I think overall it was something like 31 adults, 31 children. And so I would say also that the sample size wasn't as large as you might, but it's fascinating. And I need to talk to Deanna again about this in more detail, that the patterns that are seen in the normal control children are very similar to the patterns that are seen in the adults with Tourette syndrome, and vice versa in terms of the patterns that we're seeing in the children with Tourette being more like the adults with in the normal control group.
and that's the fascinating and at the same time confusing part. And I missed the part about the SMA and not being included in this study. So.
Well, I didn't mean to say it wasn't included, but the data, when they looked at the big data, you didn't see a big ball of activity right there at the SMA that I would have predicted if somebody had asked me ahead of time what areas of the brain are activated. And if you're looking at, this kind of pattern of activity. On the other hand, the data they were looking at was resting state. So who knows how many tics the individuals was having during that time, but presumably they were having some. And why wasn't the SMA one of the areas that was, clearly activated? And so I think that's another question, but the reality is, of course, the more we learn and the less we really understand, and the more real data that we need.
Okay, that's fascinating. Thank you very much. And now we have some time for a couple of questions, if there are any from our colleagues. I have basically one question, and basically two questions myself. One is with regards to MRI, functional MRI guided neurofeedback you introduced. And I think you mentioned the question of enduring effects of neurofeedback, or the lasting effect of neurofeedback, fMRI neurofeedback is still an open question. We don't know the answer to that. And my question is with regard to the clinical implication of these findings, and how far are we in terms of getting to clinical, daily routine clinical application of MRI guided neurofeedback, because this is quite expensive, and it's still at this point, I think it's more experimental research trial, maybe, right?
Yeah, no, I think the point you're making, Javad, is a good one. And basically, how realistic is it to try and implement an intervention like this at scale for individuals with this condition? And I think that the reality is that even in a place like Yale, you know, it's not so easy. On the other hand, the wonderful thing about it is that it puts the patient in charge.
Right.
It actually it sort of enables them. You're the one that can actually make a difference with regard to the level of activity of this particular area of your brain that we know plays an important role with regard to your tics. And I guess in my conversations, this is more qualitative analysis, my conversations with individuals who have been part of the trial, is they were very positive about the fact that they actually were in control. The doctors are wonderful, thank you very much, but let me make a difference. So the other thing that this leads us to in terms of the, is there any way of having some similar effect with real-time activation, you know, using some other strategy besides the fMRI machine?
Mm-hmm.
And, you know, there are all sorts of things people are doing with EEG monitoring and things of that sort that are a bit more feasible. Although what's interesting about when you're looking actually at the activity in the brain using EEG, is the specificity in terms of the exact location is much less precise than what we were able to do in terms of coming up with just a few voxels that were key to the individual's tic symptoms that we were asking them to control. Yep. So it's a fascinating, but you know, it's an area that is continuing to be explored.
Yeah, that's good. Thank you. Is there any questions? Okay, Dr. Carver, you go ahead.
Yeah. Thank you, Professor. I'm Janusz Kave, second year resident of psychiatry. My question may make no sense, I know, but I want to ask you about that you told us we can find out the pathway between motor cortex and the basal ganglia, and I don't know, blame it for this Tic and Tourette syndrome. Am I right?
Yes, no, there's a lot of data that implicate the basal ganglia with regard to Tourette syndrome and its severity. I guess some of the data isn't just from neuroimaging. We also published a paper that is fairly high profile, looking at post-mortem brain tissue and comparing what we found in the areas of the brain, the basal ganglia, compared to normal controls. And we found very different patterns. And as I mentioned in my last presentation, one of the big markers was actually activation of the microglia in the basal ganglia of individuals with Tourette syndrome, and other indications that some sort of inflammatory process was at work, at least in the refractory Tourette cases whose brains we actually had access to be able to monitor. And of course, that leads us to this other discussion about the Sydenham's chorea and the pandas and the post-streptococcal neuropsychological syndromes that are associated with that. But there's very strong data from a number of different perspectives about the brain circuitry and how that's altered in Tourette syndrome. But given the heterogeneity of Tourette, just because you look at averages doesn't mean that you actually have a deep understanding for this particular person in terms of their symptoms, and particularly what the progression of their symptoms will be over time. And of course, we've looked in detail at that with regard to what's fascinating is that there are indications that, you know, what happens very early in brain development matters, you know, whether the mother was smoking, whether the mother had a fever during the pregnancy. And this was well before, you know, there were any symptoms of tics at all. But it is an emerging area of science, but I'm not sure I answered your question.
I was wondering and thinking if we can find these pathways, you know, then if we know this is the pathway that we should blame for the syndrome, for the Tourette syndrome or Tic syndrome, can do some kind of intervention, you know, like putting PBS into the brain or I don't know, maybe using some surgical methods to just cut these pathway. And I was just asking for this kind of intervention. Are they helpful?
Yeah, so I'll be glad to share with you and Javad some of our recent papers, but what you're describing is exactly the progression that we have gone through with regard to some of the clinical studies that we've done. So there are patients that I have literally followed for decades, and if one intervention didn't work, I'll try another. I'll usually try the behavioral interventions first and the pharmacotherapy. Then I usually will try a variety of different pharmacological agents in combination with one another if that wasn't successful. And eventually, if none of those things are working, I will try other things. And in the case of the PANDAS cases, or the, you know, sometimes we might try some other interventions that would actually focus on the immune system. But the other ones that come to mind are electroconvulsive therapy, as well as transcranial magnetic stimulation. And we basically have published on each one of those. And for the patients that have not responded, and I think, interestingly, the first author of that paper that we did looking at the deep brain stimulation was an Iranian colleague that I met in Tehran the day after she got married. And she's now with us here at Yale, Ria Matlaq. And she's still very actively engaged, although she has her own clinical practice now. But she, for better or for worse, went through, again, another course of training in psychiatry here at Yale before she became an independent investigator and scholar. So, and then I guess the other case that comes to mind is a young man who did not respond to the DBS. And actually, we had the neurosurgeons over the course of probably 5 or 6 years, and he had surgery done here at Yale, also down at Mount Sinai in New York, as well as up at Harvard. And none of the DBS placements actually helped this young man. And that actually led us to do a neurosurgical intervention that was done up at Harvard, that was done in part because of his refractory obsessive compulsive symptoms as well as his tics. But what was fascinating about this young man, that there'll be another paper coming out about him within the next year or so, is that his tics were just on one side of his body, just on the left side of his body. What's going on that the tics would only be happening on one side of his body? But I agree with you completely. There's a progression. And one of the papers that we may discuss in a few minutes when we discuss this refractory OCD case, who's 19 years of age, is a recent article by the group up at Harvard, where they were basically looking at the sequence of things one should do for refractory obsessive compulsive disorder. But we'll talk about that in a few minutes.
Okay. Okay. She has a question for you.
Hello, Dr. Leckman. This is Mahtab Mohamed. Once again, I want to say that I am too fascinated about the age specificity that you said about the functional connectivity in children and adults with Tourette syndrome. I have some questions about this. Can we conclude that Tourette syndrome in children and adults are two distinct conditions, or maybe we can conclude that brain in Tourette syndrome may develop in some way different from normal people in some, I don't know, some different pathways. Can we conclude that?
Yes, so a very good question. Thank you for asking. I think the takeaway messages from the paper that was recently published by the group at Washington University in St. Louis are that the pattern you see in Tourette is different than the pattern you see in normal controls. They have a distinctive set of circuits that are actively involved. And as I say, this may be one of the features that may actually lead some of them to be perhaps more creative than the rest of us, or seeing the world in a somewhat different way than the rest of us see the world. But the really fascinating finding from that study, and it's the one you mentioned, is that the pattern of activity that was seen in the adults with Tourette versus the children with Tourette were quite different, and they were sort of polar opposites in terms of the associations that were seen in the normal controls. What's interesting in that paper too is that they don't really present the adolescent data, and presumably they are somewhere in between, and it may not really fit one pattern or the other that you would actually be seeing. And the other feature about Tourette that is certainly worth mentioning is that the longitudinal studies that we've done over time have very clearly documented that the worst ever tics occur early in adolescence, age 9, 10, 11, 12, and then for most of the individuals with Tourette, they get better. Although what's interesting is that although they get better, there usually is a persistence of tic behaviors that is normally seen. And the worst ever cases are the adults, who have self-injurious tics, and the case that I was telling you about that was refractory to all of these treatments, including 5 courses of deep brain stimulation, is that he was hitting himself on the side of his left side. He's blind in one eye. He's chewed away part of the inside of his cheek. He's bitten off part of his tongue. I mean, it's really horrific in terms of the tic symptoms he has that are just limited to the right side or to the left side of his body. And of course, given the asymmetry in our brains, we've been focusing in terms of trying to have a deeper understanding by looking at what's going on the right side of his brain. But there's still a lot of questions we don't have answers to, but this is just another few steps along the way.
Okay. So maybe we could conclude, or maybe one of the hypotheses for explaining this data maybe is that those with adult Tourette constitute a different subgroup of patients with Tourette syndrome versus those who have been included in the study as children with Tourette syndrome. Would it be one of the?
Yeah, no, and I think it's fascinating too, because clearly the ones that they've selected who were adults with OCD have a persistence of their tic symptoms.
Oh.
And the fact that they have a pattern of neural activity when they was looked at through this big data analysis, more similar to normal children, and that is totally weird. I mean, that is just doesn't make sense to me. But that's what happens sometimes with the data we get. And I do think that our field and having access to big data through machine learning and the rest of it, I mean, that is certainly one of the realities that we're looking at in terms of the opportunities for studying things. But why on earth would that be true? And how can we have an integration of the information that I was presenting about the circuitry that was sort of defined by sort of the old school methods versus the circuitry that's emerging from the, the big data analyses.
Yeah, that's quite possible. Okay, thank you. So if there is no more question, I want to move on to a case. I just ask you to listen to this case, and we just want to have your consult. This is a case we have been seeing for so many years. I was involved mostly in the early years when he was in his adolescent years, and now he's being followed by some of other colleagues we have. Basically, he's a case of chronic OCD, but his OCD symptoms are more like Tourette syndrome, usually preceded by some urges. And my colleagues who are involved in his current current clinical care are also available online. So I just start by just touching on some of the clinical features of his, and then of course my colleagues are available. They could jump in anytime they want to. So is that okay to move on?
Yeah, please.
Okay. So this is a 20-year-old unmarried man who is in his ninth grade. Is still living with his parents. He's been admitted to the hospital many times. So for 14 times in the last 5 years. He's been recently hospitalized. He's now in the hospital right now after having several bouts of verbal and physical aggression. And basically, aggression is the main challenges we all have been facing with. The aggressions were mostly toward his parents without any identifiable triggers for the most part, and he attributed this to recurring thoughts. After aggressive burst, he admits that all these thoughts are only in his own mind and his father had never attacked him. Um, During his recent hospital stay, he kept having such thoughts while repeating some sentences and behaviors. And these are more like tic-like behaviors. He's very preoccupied with the right way of doing things and even numbers. Um, he was born into a middle-class family with a history of aggression and psychiatric hospitalization. There is at least one hospitalization for psychiatric reason in his uncle. No birth problems, except for suspicious history of febrile seizure. There are not good detailed history about his early childhood, but other than being a difficult baby, um, for apparently there is no history of stuttering, tics or repetitive behaviors in early years. No clear history of his social development is available, but we could assume that there has been no rich social life in his early years. Um, um, his educational status was okay. Um, Not apparent history of dropout, but he's not a bright person. He started having deterioration when he was in seventh grade. Um, his major symptoms started in 2013, 7 years back, when he was 14, with aggression, agitation, deterioration in educational status. Um, it was there is a report of sexual assault back then. In the same year, due to frequent violent behaviors at school, he was expelled from the school. In 2016, he developed verbal and physical aggression toward his family, along with increased energy, decreased need for sleep, symptoms of bipolar, perhaps mood disorder. At this time, he was admitted to the psychiatric ward. For the first time, he was diagnosed with bipolar 1 disorder, manic episode. Shortly after discharge, he was hospitalized again with the same symptoms as the previous one and received the same diagnosis and treatment again. There was another hospitalization in 2018 with mood symptoms. Back then, he was also diagnosed with comorbid autism spectrum disorder and intellectual disability. A few months later, he was hospitalized with some symptoms of such mutilation and repetitive urges and behaviors, loss of appetite, depressed mood, and lack of communication. His self-mutilation symptoms were very refractory for a while. We had very difficult time controlling those symptoms. As some examples of his self-injurious behaviors are stabbing his eyes with knife, tongue biting, skin picking, drinking hot water leading to ICU admission, doing repetitive Valsalva maneuvers, stimulating his throat with a fork to start gag reflex, holding a lamp to burn his hand. And again, he's been admitted several times with the same diagnosis of mood disorder, OCD, intellectual disability, and also ASD symptoms. And there has been many medications tried for him, including antipsychotics, first and second generations, mood stabilizers, antidepressants, and not surprisingly, antidepressants were not helpful, have not been helpful for him. And there are other medications with no apparent positive impact. So I pass on this. At this point, he currently he receives clozapine, 850 milligrams, with no considerable effect. And there are, and he's still in the hospital, and there are talks among colleagues regarding next possible steps in terms of his treatment, including DBS. So basically, the main question is how we can be of help in terms of his obsessions and OCD symptoms and impulsive aggression. His aggressions are apparently related and secondary to his OCD symptoms. And the related question is if we could consider DBS or any perhaps possible options to be effective for him. He also has many other challenges as well. Those challenges are typical of his age, transitional age challenges, like lack of specialized services for this age group, difficulties with job placement, socialization, vocational support, etc. But for this topic, for now, I think what we need most is what we can be of help in terms of his psychiatric treatment. Any help?
Well, I guess I'm impressed with your determination to try and make a difference for this young man. And it must be a real challenge for his family. How many brothers and sisters does he have?
He's not the only child.
One of the things to mention, although I doubt if it's anything that's a serious issue for this young man, is something called accommodation. And sometimes when we see aggressive behaviors in our OCD patients or our Tourette patients, when we actually go at a deeper level, what we find is that their anxiety in some way is asking for reassurance from their family. Will you do this for me? Will you do that for me? And it turns out that although if the family gives in to the urge to respond to the child's request, it can actually be self-reinforcing in the sense that they will be asking again sooner rather than later to actually have something be done. And if the parents don't respond, then they can sort of up the ante by becoming somewhat aggressive. And I could send you a few papers about family accommodation, and there are interventions, interestingly, that are mostly focused on the parents. That said, for a 19 or a 20-year-old young man, and what's interesting about the accommodation, it happens much more frequently where it's the only child, where this is the only focus for the family in terms of moving ahead with the development of that child. That said, the fact that he may be on the spectrum of autism the fact that he may be on the bipolar spectrum, just again speaks to the inadequacy of our diagnostic classification system and the fact that we're using descriptors rather than anything that's sort of based on, hard biological, electrophysiological data. And I guess the other thing that I typically will say to families when I'm presented with a case similar to this is that I'm in favor of whatever works. And I usually would have a progression, and you've already have been well on your way with regard to that progression in terms of, the behavioral interventions, the multiple pharmacological interventions that have had minimal effects. And now you're considering doing other interventions, and they, of course, include ones in which we're directly affecting the brain. I don't think the data is very good with regard to refractory OCD, with regard to ECT, but I did send you recently or I think probably this morning or yesterday, this paper from Harvard, where they literally, I think, had, how many different steps along the way? But they had these various nodes, this algorithm, and basically the figure that you can see here is these 7 nodes.
Yep.
And so you might share that with the group on the inpatient service. And basically, I think he's at least gone through all of these up to node 4. Mm-hmm. And he may have tried some of the ones with regard to node 5 in terms of other agents like lamotrigine or in acetylcysteine, riluzole, topiramate, but some of those agents probably aren't available there in Iran.
There are, actually we have.
Yeah, so I would potentially give those a try before going ahead with a more invasive procedure. The transcranial magnetic stimulation is an interesting option. Mm-hmm. It really is so time consuming in terms of, having the magnetic electrodes in place and making sure that they're in exactly the right way. Interestingly, that was another project that Dr. Matlog was involved in doing over the course of time when she first arrived with us. But it's certainly worth a try. And what's interesting is I just sent you another paper where they were using a different version of TMS that's called deep TMS for OCD. And I'm not sure if that product is potentially available, but it's basically a version of transcranial magnetic stimulation that actually goes into at a deeper level in terms of the intervention. And there's at least a beginning of a set of clinical trials that looks like it's fairly promising. But given his age, I probably would probably start with the TMS or the ECT before going to the surgery. On the other hand, he's so refractory, I would really be tempted to consider something like the DBS as a possibility. Although it's interesting too, I sent you the other paper from Harvard where they basically took a look at this intervention using a I wouldn't say it's non-invasive, but basically using these ways of having these electrodes come in and pinpoint particular areas of the brain, so you don't actually have to go through a surgical procedure to actually have the effects of lesioning that particular area of the brain. And it's called magnetic resonance guided focused ultrasound capsulotomy for the treatment of treatment-resistant psychiatric disorders, which he certainly would qualify for. Mm-hmm. So that's one where there's fewer, because the DBS, I mean, it's so complicated because you need to program the DBS electrodes. You've probably been down that road, and they're needing to come in and have those monitored. And I probably have 10 patients with Tourette Syndrome that I regularly am in contact with who have most of them have had a positive response to at least one placement of the DBS electrodes. But if there's any way of doing this magnetic resonance guided focused ultrasound capsulotomy, it might be worth a try for this young man. The other one that you mentioned along the way was, is there any way in which cannabinoids would be helpful? I don't know, what has been his experience with?
Actually, we don't have it now, and it's still something we have to explore, you know, in terms of getting cannabinoid. But do you think that's worth trying?
Well, as I said before, Javad, I'm in favor of whatever works.
Yeah. Okay.
And interestingly, the young man I was telling you about who has the one-sided tic symptoms, his family, he was raised in Connecticut, but he actually, the family moved to Rhode Island, and the reason that they moved to Rhode Island was that medical marijuana was available in Rhode Island, but wasn't available in Connecticut.
Yeah.
And interestingly, if it was up to me, I would say get a product that has very high levels of CBD, but the THC is something that the patients actually prefer because it gets them high. And interestingly, this young man, he frequently will be in touch with me asking me to see if I can convince his parents to make sure he gets a product that has a higher level of THC. And there was recently a study that was done, I think it was based in Michigan, but basically it was both in Canada and across the United States. But there was a big survey about what people preferred. And of course, the Tourette patients, and this was a Tourette cases, all preferred the ones with the higher levels of THC rather than the CBD. But if you have access to CBD, and I'm pretty sure Iran was right there at the beginning in terms of the cannabinoid, you know, experience. So I'm sure there are some traditional providers that could certainly give you something for the family to use.
Yeah, practically we could do it, but not officially. And with regard to TMS, is SMA the target you are recommending if you want to try that one?
Well, that's the one for the Tourette syndrome.
How about OCD?
But for the OCD, the one that was used.
DPL, dorsolateral PFC is the one.
Yes.
So that's the same.
And then there's the whole question about unilateral versus bilateral. And I think typically we would probably recommend the bilateral.
Okay.
But for somebody his age, but he's, it's interesting in terms of the surgical procedure that they did up at Harvard, that they actually have this, this clinical trial for. You know, it was, I think the youngest patient was 26 years of age with refractory OCD. But I think following that different nodes, the 7 nodes from the Harvard study would make a good sense to me.
Yeah, that's a good guide too. Bandot, one of our colleagues who is currently in charge of his clinical care, has some questions for you. Please go ahead. Bandot, are you there?
Hi. Yes, I'm here.
Okay.
Hi, everyone. Can you hear me?
Perfect.
Java, can you hear me?
Yes, perfect.
Okay. Hi, everyone. My name is Vanda Sharif. I'm a psychiatrist, and I work in the same department that Javad is working. I had the opportunity of working with him for the last 20 years. And it's really an honor to have you, Professor Leckman, in this webinar series. And I really enjoyed your thought-provoking presentation. Before moving on to the discussion about this case, that's my patient actually in this time, and I'm struggling with finding a medication or treatment effective for him. Before moving to that, I just want to refer to one of your unanswered questions with regard to the Tourette syndrome study that you started in the US. And that was about the possibility of working with Iranian colleagues on replicating this study. I really hope so, and because I think that we have a large and strong body of young researchers who are very interested in doing such cutting-edge research. And for that purpose, I really look forward to November 3rd, and I really cross my fingers if something happens in your country. So let's move on to the discussion about my patient that is now in my service. As Javad has presented this case, we are struggling with finding a treatment that's effective for these recurring urges and thoughts. And we had tried an exhaustive list of medications and also electroconvulsive therapies that are found to be ineffective. But we didn't try TMS yet or other novel medications that just recently I noticed in the paper that you have sent us, and we will try to consider them. But I have a question for you. I have actually two questions. One is, do you have any advice on the number of TMS sessions if we try TMS for this patient before moving to neurosurgical methods? That's my first question. And the second question is that, do you recommend using ketamine for this patient, as I recently noted some papers on trying ketamine for treatment-resistant OCD?
Well, ketamine is a wonderful product, and I guess the really great advantage of ketamine is that you can see actually the benefits, you know, within a few hours or a few minutes of actually using the product. So if that's something that's available to you, as I mentioned to Javad, I'm in favor of whatever works. I guess in my experience, it's been something that has been, you know, more beneficial for people with depression and with some other forms of illness, but I'm in favor of whatever works, and I think ketamine is an interesting alternative. In terms of the TMS, if there's any way for you to do that, whatever it's called, the deep TMS rather than the RTMS, I guess I would probably recommend that. On the other hand, for the RTMS, what we found was typically to do sort of bilateral stimulation, and I think there was something like at least 15 or 20 different sessions, and it's a very time-consuming intervention in terms of having, and so we were very fortunate to have colleagues like Maria Matlag with us, who actually was the person who, the other thing that is really critically important on the RTMS from my experience is really making sure that the location is exactly where you want it to be with regard to what's happening in the brain. And there are various devices that can be used to actually help ensure that that's the case, where you actually have an image of the individual's brain sort of presented, and it's an actual real image from an MRI that was done that actually allow you to see exactly the physical location of different brain regions for that particular individual. And I guess that's another question for you, given the fact that over the course of time, there has been this behavioral change. Has there been any change if one has looked at even the structural MRI with regard to this patient? Has there been any kind of loss of white matter or gray matter that has been seen over the course of time with this young man, or not really?
Vanda, you wanna go ahead?
Yeah. Actually, we just had one recent imaging, and in that recent imaging, we did not observe any loss of volume, just a cisterna magna was observed. But other than that, we had no abnormal finding or loss of volume or we didn't have repeated MRI, so we cannot say if we observed any change in the volume of the brain.
I guess the other big question is, given the realities in Iran, are there any kind of residential facilities that a young man like this could be part of, or that just isn't part of the usual scheme of things in terms of available options for intervention? I think our connection may have...
Yeah, there are some residential facilities, but their parents' preference is not to move to this option. So we may consider it as the last option if nothing else works.
So it's an interesting question, although it may not be appropriate, but what are the strengths and interests? What are the things that this young man, when he's not having some sort of rage attack, or what does he enjoy doing and what is he good at? What does he look forward to in life?
Actually, can you hear me? Actually, he don't enjoy any kind of social relationships with peers, but he really loves doing some soccer or doing some PlayStation games. But other than that, we didn't observe any enjoying recreational activities for this patient.
Does he have any interests that are sort of really deep interests for him, things that he's really focused on in terms of almost like an individual with high functioning autism, where they have a specific, preoccupation about particular topics?
Not very intense, because almost in the last 5 years, at least for the most part of it, he was obsessed with the things, with his thoughts and his urges. So most of the time he was affected by his illness. So he didn't have time to enjoy the other things that could possibly have effect for him.
It's an interesting issue too about the football or soccer, and it would be it's just fascinating to me that in Tourette Syndrome, if somebody is doing something that requires focused attention and motor control, like playing a piano, but also if you're taking the ball down the field in football, typically their tics disappear, and if there's any way to sort of engage him in activities like that, perhaps with people who are, and it's fascinating too, I guess when I was up in Canada, when I was still in training, I was at the Hospital for the Insane in McGill, and what was fascinating was that they had these groups of children or young adults where they were the ones that were responsible for looking after everything, but they also had games that they played, things they enjoyed doing together, and there may be a disadvantage for him not to be part of a community of other individuals who have similar kinds of difficulties. But that's just speculation. But he's very fortunate to have you, Navad, as a person that's looking after him, and good luck. And I'm in favor of whatever works.
Thank you. Thank you very much for your good advice. Thank you so much.
Well, I wish I had a good answer. But inshallah, there will be something that makes a difference.
Thanks.
Just one thing with regards to TMS. Deep TMS for now is not a possibility for us because of the required coil. We don't have, but we could do the RTMS protocol for him. It's maybe work, maybe it doesn't, and maybe not. So that's one option.
Yeah. So if you look at the one of the papers that I sent you, the one that has those 7 nodes, they go through, and the last paper about the RTMS for OCD was actually a meta-analysis. And so there was a variety of different papers that they were summarizing in that brief paper, and they frankly weren't too impressed with the overall impact, but then they highlighted the fact that this other new product was now available that did have, at least initially, some very positive responses. That said, I think the RTMS is certainly worth a try, although it is time consuming.
Okay. Thank you very much. It was very helpful. I enjoyed it a lot, and I assume that everyone else is also enjoying, and they have enjoyed your presentation, wonderful presentation. And I hope we could work together as you promised, so to replicate some of the findings, hopefully. And by the time we get to the point we could collaborate, perhaps November the 3rd is just around the corner, and we could get started.
Well,
so,
it's really a tragedy what is happening in our world today.
yeah. And thank you again.
And thank you for inviting me to be a visiting professor.
Oh, okay. That's our privilege and the honor for us to have you as a visiting professor. Thank you.
Shukran. Thank you.
Okay. Bye-bye. For now.